Okay, thank you very much for inviting me to give this presentation. My name is Jakob Grauslund. I'm a professor at the Department of Ophthalmology, working with diabetic retinopathy, and I was very encouraged by the discussions and the presentations this morning, which really put a lot of focus on this issue. And in particular, I would like to thank Sune Holm for raising some of the struggling issues that we're working with every day as eye doctors. So last week, I had the honor of hosting the largest conference on diabetic retinopathy worldwide here in Odense. And there were a lot of presentations on artificial intelligence, but there were not a single presentation concerning the ethics. So I think this conference is so important because we are not at that state yet as clinicians. So thank you for raising the attention for this. Yeah, go. Okay, I'll just provoke you a tiny bit here in the beginning. So as some of you might know, this is something called the Gartner's hype cycle. So every time you have an emerging technology, like artificial intelligence, for instance, then you would probably go through these stages. So on the horizontal axis, you have time, and on the vertical axis, you have expectations. So in the beginning, you have the innovation trigger, and then you have a lot of expectations. And at some point, you reach the peak of those kind of inflated expectations, and then you go down again until you hit the valley of death, the trough of disillusions. But from that point on, I think that's the most important stage for us as clinicians, because then you advance to the stage which is most important. So I'm not a front runner in this field, but I would very much like to be part of this final step, this step which would lead us into implementation in the clinical world. So that's really the aim that I have as an eye doctor working with diabetic retinopathy and AI. Okay, so ophthalmology, eye disease. This is actually the specialty, the clinical specialty that has the highest number of patients. We overtook orthopedic surgery a few years ago. So it's a lot of patients, it's a visual medical specialty, and it's so important for us to use imaging to assess disease. So we really use a lot of technology, a lot of images like radiologists do. And of course, this gives us an unmet need to use automated solutions. So turning into diabetes now, this is a global epidemic, and it has been demonstrated that in the United States, 1 of 3 newborn babies will develop diabetes. So that's really a lot of persons. So diabetic retinopathy, diabetic eye disease, that is by far the most common complication in diabetes. And actually, there's a 10% risk of blindness in what we are calling type 1 diabetes. Fortunately, 90% of all vision loss is preventable if we do eye screening. So that's really the ball game here, that we need to do eye screening to prevent blindness. So this is the chart that I'm working with every day. You have some green categories and you have some red categories. Don't bother about the technicalities with the names, but just know this. We have a scale from 0 to 4. So that's the level of retinopathy. If you are located at stage 4, then you should go from the green category, where you are getting screened, to the red category, where you need treatment in order to avoid blindness. Likewise, we have something called diabetic macular edema, which can be present at different stages. That makes things a bit complicated, but you have that also as a red category. So this is the purpose of screening in diabetic retinopathy. You need to identify patients in one of the two red categories, because these patients would need treatment even though they may not know it. They don't have any symptoms, but they will probably get blind if we don't treat them. So that's the purpose of screening. And then Sune really had some great presentations about the IDX-DR system, which was FDA approved as the first one some years ago. So what this system does is that it identifies patients with level 2 or above. And I cannot use that in Denmark. We made some calculations. If we implemented this system in Denmark, then it would identify for us all patients with level 2 or above. But I don't need those patients in the clinic. Actually, if I had all of these patients coming into the clinic, then I would have a 90% false positive rate. So 9 out of 10 patients would be false positives. So that's why I cannot just copy paste some of the solutions from the IDX-DR group or from the Singapore group or from other good companies or good groups who made some pivotal research on this. We need to do our own systems which are focused on Danish patients and upon the images that we use in Denmark. That's the only way we can make this successful. So how do we do screening? So this is the regional eye screening team here from southern Denmark. So what we have is basically a telemedicine approach. We have a centrally located grading center here in Odense called Grading Center SDCO, Steno Diabetes Center Odense. And then we have some cameras located at 7 different locations at the diabetes departments in the region. So Tønder, Esbjerg, Grindsted, Kolding, Sønderborg, Odense, Svendborg, and soon VIOLA. So we have cameras at all those locations, and then we have an eye doctor looking at the images coming in. So this is a workflow. First you have imaging. So patients go to the nurse maybe, or the optometrist in Kolding, for instance, and images are taken of the eye. These are sent instantaneously to Odense, where we have an eye doctor working on these, looking into the image, giving a feedback to the local department, and then the patient will have an answer within an hour. In this approach, we screen 15,000 eyes every year. And she's looking a bit tired, isn't she? So she's got a lot of work to do. Sometimes she do images for 100 eyes every day. So kind of like the poor radiologists really have to do this work over and over again. And it's difficult because you have to avoid fatigue and you have to keep up concentration. So that's challenging for such studies. So these are my clinical needs. First of all, I need some automatic evaluation to help me. And secondly, I also need some kind of virtual staff training, and I'll also address that briefly. But most importantly, the automatic grading. So in Denmark, this is a number of patients with diabetes, and you can see this is just increasing and increasing. And every person with diabetes needs diabetic eye screening from the day of the diagnosis till the end of time. Every single patient in Denmark with diabetes needs eye screening all life. And this is a burning platform. So we have an ever increasing number of patients, and like Ole, we do not have any more healthcare providers to help us. So we are getting a higher workload for every eye doctor here. So I'm teaming up. I was teaming up with Professor Tiosius Savarimutu some years ago. He knows all about artificial intelligence, not so much about diabetic retinopathy, and I was kind of the other way around. So we tried to team up to look at these things, and we've been working together for 8 years now, and I think we just initiated the 3rd PhD we have in common on artificial intelligence. So basically, working with diabetic retinopathy, you have two kinds of solutions if you want to do machine learning. You can do what is called classic programming, and this was initiated some 15 years ago. It has a great sensitivity, but specificity is not that good. So classical programming is very good at identifying screen-positive patients, but you get way too many patients referred. So the new kid on the block, which we also heard about this morning, is deep learning. And this is fundamentally different than classic programming. So in classic programming, you have some data and some rules which you put into the computer, and then it comes up with some answers for you. With deep learning, you go the other way around. So here you would say, these are the data, and this is the answer for the images. So if I want to train diabetic retinopathy screening with my computer, I give it a lot of images. 70,000 is probably enough. And then for each image, I don't tell the computer anything except the level of diabetic retinopathy. So that's at level 4, that's a level 2, that's a level 1, etc., etc. And then the computer does all the math and all the thinking. So deep learning is like how the human brain is working. So here you just have a computer processing all the data and giving you an answer. In the human brain, you have the neurons of the brain with a lot of dendrites, which you would use to collect all the data you need. And then you will have the axon, who will be transmitting some kind of signal. And that's the same with deep learning. And with a lot of data coming in, then you could adjust all the variables that you use for the neurons, and then it will give you the right output in the end after a lot of thinking. So basically, this is all about image recognition by experience. That's all it is. So this is just an example of one of our ongoing PhD. Jakob is a computer engineer working at the Mærsk Mc-Kinney Møller Institute. He is finishing up his PhD this month, and he is looking at a deep learning algorithm for our hospital-based screening. And he has two elements in this. Firstly, he's looking at something we call segmentation. And segmentation is kind of looking into the black box of the computer. So here the computer is drawing up some of the features. You cannot possibly see that image, but there are some nice features and the computer can draw up these. And then we have this black box and you can say, the reason that the computer decided on this was that it had marked up some things over here. So that's one of the things Jakob is working with. The other thing, which is most important for me as a clinical doctor, is classification. And classification that just gives you the output that you need over here, the level of diabetic retinopathy. And he's working now on our images to produce this. And I think he has data from 35,000 patients or something. So that's very nice. So that was one of the aspects, and here in the end, I'll just introduce some of the ethical concepts, and I think these were very nicely discussed also this morning. So obviously, we have the risk of missing non-diabetes related disease, because the computer, the algorithm, is trained to detect diabetic retinopathy. That's it. That's it. But you might have other diseases. And an example of this would be something called retinitis pigmentosa, which you have here and which you cannot see as well. That's a blinding disease. You can get blind from this, but there's no cure. So would you want to know that you have this disease, or would you rather go undetected? Another example is something called a choroidal melanoma, which is kind of a tumor in the eye. This is a life-threatening disease. So obviously you would like to have this detected. But the computer and the algorithm is not trained to detect rare diseases. So there might be a tiny risk of missing these melanomas. We only have like 50 of those in Denmark every year. So it's almost impossible to train the algorithm to detect these. So that's the risk that you are taking, that the computer is excellent at detecting diabetic retinopathy, but it might be missing something that the human grader would not miss. So that's a dilemma that we're working with. So the final thing I would talk about is this training of our staff. We have a lot of staff assisting us, and for this we develop an online training system and a platform called VIOLA, which we just implemented to training for all ophthalmologists in Denmark. We have invited 500 ophthalmologists now to join this course. This is some level-specific courses to help people grade diabetic retinopathy. We have some video demonstrations, and we have some interactive marking tasks, and I'll come back to those in a short time. And then a final certification test. So we try to make some training programs virtually. And we had some deep learning or AI aspects in this as well. We have something called adaptive learning. So you get the course that you need. So if you demonstrate that you're very good at detecting one thing, then you will not get more training images for that. And if you are not so good, then you will need additional training in some aspects. And then we also use something called segmentation by crowdsourcing, which is that we are getting a lot of data from our viewers now, and we can use that to optimize some of the algorithms. These are some of the marking tasks that we are using. So basically, we put in a lot of images, and for those images, when we had the Corona period and I was at home, I drew up like 37,000 images or small drawings on these images. So we have some kind of ground truth. So we have a lot of images now, and all lesions of diabetic retinopathy on these images have been marked now. So we can train our people, our students to recognize different parts of the images and saying, hey, you need now to identify some hemorrhages. And then they can go into the image and they can point at some of those hemorrhages. And then the computer will tell them if they got the image right, if the expert had also graded this. So working with images, I think that's a fantastic platform, and we are so happy with the collaboration we have with our partners at the Maersk Institute for this as well. So you have those training programs. The students are asked to draw up some things on your images, and then you will compare the answers from the students with the answers of the experts. And then you can see, well, you did 78% on what is called microaneurysm. So you're very good at that. You would not need any more training. On the other hand, you only got 58% on this ERMA thing. So you will need some additional training for this. So these are the lessons that we have so far, and this will be the final slide. Avoid the hype. Go for the solutions that matters for patients. In ophthalmology, that's a ground truth, because there are already a lot of papers in Lancet and the big journals, so you cannot compete with those. You need to do something that matters instead, which is implementable for your patients. And for me, it's absolutely essential to have some strong collaborations with our dedicated partners at the Maersk Institute. So we would not have made any kind of progress if we did not have that. And the ethical dilemmas, there's a risk of missing disease, and there's also a risk of detecting non-related disease. So that'll just conclude the talk. Thank you.